Today, we are examining prolonged grief disorder, how to recognize it, assess it accurately, and intervene in ways that are clinically effective while still respecting the profound human experience of loss. This training is grounded in current DSM-5-TR criteria, evidence-based treatment models, and trauma-informed practice. My goal is not to pathologize grief, but to help us identify when grief becomes persistent, impairing, and functionally disruptive, and how we can support clients in re-engaging with life without minimizing the depth of their loss. Across this training, we will walk through diagnostic clarity, differential diagnosis, assessment tools, core treatment approaches, and the realities of working with clients whose grief feels stuck. Prolonged grief disorder refers to grief that becomes clinically significant and functionally impairing. In most cases of adaptive grief, emotional intensity gradually softens and the individual begins to re-engage with daily life. In PGD, that natural softening does not occur. The individual remains in a state of persistent emotional pain and longing, and this interferes with functioning. The core clinical features involve persistent yearning and difficulty integrating the reality of the loss. The person may describe feeling stuck or state that life feels directionless without the deceased. These experiences are specific to the attachment rather than a generalized mood state. From an attachment standpoint, the grief system remains activated, as if the separation is still ongoing. The individual continues to seek connection, even when the loss is fully understood intellectually. The result is an ongoing emotional loop, longing, avoidance, longing, without integration. It is important to distinguish emotional intensity from clinical impairment. Grief that is still painful can be completely normal. PGD is defined by the absence of movement. The grief remains dominant and disrupts the individual's ability to resume daily life. The duration of grief alone is not diagnostic. Some cultures expect mourning for long periods of time. The defining feature in PGD is functional interference, meaning the grief prevents participation in work, relationships, self-care, or role responsibilities. Take a moment to reflect on a case, client, or person you have known whose grief did not soften or shift over time. This reflection helps anchor the clinical pattern of prolonged grief as distinct from normative mourning. We diagnose prolonged grief disorder using a stepwise clinical approach. The diagnosis depends on the amount of time since the loss, the presence of specific symptoms, the persistence of those symptoms, and the extent to which the grief interferes with daily functioning. Cultural norms are essential to assessing whether the level of grief response is clinically disproportionate. The DSM-5-TR establishes a time threshold to distinguish between acute grief and prolonged grief. For adults, the loss must have occurred at least 12 months ago, for youth, 6 months. However, time alone does not indicate pathology. The duration simply marks when PGD can be considered diagnostically. These core symptoms represent the attachment anchor of PGD. The person remains psychologically pulled toward the deceased, either through longing or persistent cognitive preoccupation. This distinguishes PGD from depression or trauma reactions, which involve different emotional centers. These symptoms illustrate how grief becomes pervasive, impacting identity, emotional processing, behavior, and worldview. A person may continue to avoid reminders of the loss, or feel disconnected from life roles or relationships. The common thread is stuckness in grief's early phase without progression toward adaptation. Functional impairment is the diagnostic pivot. We look for disruption to daily functioning, not just the presence of pain. The individual may be unable to work, withdraw from relationships, or struggle with self-care or motivation. This impairment is what differentiates PGD from normative grief. All grief must be assessed in cultural context. We must avoid pathologizing expressions of grief that are expected, encouraged, or honored within a person's community or belief system. PGD is diagnosed only when grief severity exceeds what is typical in that cultural environment. 14 months after the death of her spouse, a client reports intense longing, inability to return to prior routines, persistent avoidance of reminders, and describes feeling that part of her identity is gone. She has withdrawn socially and taken medical leave from work. Based on the criteria we've reviewed, this case is consistent with prolonged grief disorder. The next step is a clinical interview focusing on identity disruption, avoidance patterns, and functional impairment. Assessment tools can support but do not replace clinical judgment. This module focuses on distinguishing prolonged grief disorder from major depressive disorder and post-traumatic stress disorder. These conditions can overlap, but each has a different emotional core. Clarifying the dominant emotional driver guides accurate diagnosis and appropriate treatment planning. When differentiating these conditions, we look at the central emotional experience rather than individual symptoms. In PGD, the emotional core is yearning and difficulty accepting separation. In PTSD, the primary experience is threat, accompanied by re-experiencing and avoidance. In major depression, the central experiences are hopelessness, anhedonia, and self-critical thinking. PGD, the distress is specific to the loss. Clients often say, "I can't live without them." In MDD, distress is global, with statements like, "I am the problem," or "nothing matters." If the client can still experience joy or engagement in non-loss related contexts, PGD is more likely than depression. In PGD, the individual struggles with the absence of the loved one. In PTSD, the distress is linked to the event itself. How the person died, the emotional quality is different, longing versus fear. This distinction is clinically meaningful. When the death itself was traumatic, both PGD and PTSD may be present. In these cases, trauma stabilization typically precedes grief integration, because intrusive trauma symptoms can interrupt the ability to process loss. When assessing suicidal ideation, listen for the underlying intent narrative. PGD. I want to be with them again. MDD. I am a burden. PTSD. I can't tolerate this anymore. These distinctions help us assess risk and clinical urgency. These brief statements illustrate the cognitive emotional signature of each condition. The language clients use is often the clearest indicator of which disorder is primary. In this module, we highlight traumatic grief presentations, where prolonged grief disorder and post-traumatic stress disorder co-occur. This pattern is most common when the death involved violence, medical trauma, or suddenness. In these cases, the grief response is complicated by a trauma response to the event itself. Trauma disrupts the brain's ability to process and integrate the loss. The attachment system remains activated, while the threat response system is also engaged. The individual may avoid reminders of the death event, which also prevents processing of the loss relationship, keeping them stuck in both domains. Traumatic grief involves two distinct emotional engines: the longing and attachment disruption of PGD, and the fear-based re-experiencing and avoidance patterns seen in PTSD. Both must be recognized for treatment to be effective. When both PGD and PTSD are present, we do not start with grief work. Trauma symptoms must be reduced first. The nervous system must be regulated enough to tolerate emotional engagement with the loss. Once stabilization is achieved, meaning reconstruction and re-engagement work can proceed more effectively. This case reflects both PTSD and PGD. Treatment would begin with trauma stabilization, likely through grounding, exposure-based work, or trauma-focused CBT, EMDR techniques. Once traumatic reactivity decreases, the client is more able to engage in grief integration and identity reconstruction. This module reviews what the research shows about who is more likely to develop prolonged grief disorder and how frequently it occurs in the general population. The focus here is on population-level data and established risk patterns, not clinical formulation. Those will come later in treatment planning. Across large-scale studies, approximately 7 to 10% of bereaved adults develop prolonged grief disorder. However, rates are significantly higher when the death is sudden, violent, or medically traumatic. Social and cultural support structures play a meaningful role in mitigating or amplifying the risk. The nature of the loss matters. When the death is sudden or violent, the attachment system is overwhelmed and lacks the chance to gradually adjust. Stigmatized deaths, such as overdose or suicide, add additional barriers to support and meaning-making. Loss is not just emotional, it is relational, identity-based, and role-based. The more central the relationship was to the person's daily functioning or sense of self, the greater the vulnerability to PGD. Both close and unfinished relationships can contribute to prolonged grief responses. Existing mental health vulnerabilities can make it harder to adapt to loss. A person with limited social or emotional resources may not have the capacity to metabolize the grief without clinical support. Culture influences not only how grief is expressed, but whether grief is validated or suppressed. Contexts that minimize, privatize, or judge grieving behavior increase risk for prolonged or complicated grief outcomes. This case contains multiple risk factors that increase the likelihood of PGD. It does not determine the outcome, but it does flag the need for monitoring and early supportive intervention. In this module, we'll review how to clinically assess for prolonged grief disorder using structured interviews, validated measures, and clinical observation. The goal is to recognize PGD accurately while avoiding overdiagnosis of normal grief responses. The assessment of PGD should always start with function. Duration and emotional intensity alone are not diagnostic. We integrate standardized tools with clinical reasoning to evaluate whether grief has become persistently disruptive or maladaptive. PGD is multifactorial. We assess attachment history, loss context, emotional tone, and cognitive themes such as disbelief or guilt. We also examine behavioral avoidance and role functioning. Finally, we frame all findings within the client's cultural and spiritual worldview. These screening tools measure frequency and intensity of core PGD symptoms such as yearning, emotional pain, identity disruption, and meaning loss. The PG-13R aligns with DSM-5-TR criteria, while the IPGDS is useful for international or cross-cultural populations. Screening tools highlight risk but do not confirm PGD independently. Elevated scores should prompt deeper evaluation of functional impairment and contextual fit. Use these findings to guide clinical formulation and select the appropriate treatment approach. In remote or telehealth settings, assessment must include safety and emotional containment considerations. Confirm privacy, watch for physiological stress signals, and plan for grounding or follow-up if distress arises. The goal is accuracy without destabilization. This vignette illustrates a clear PGD presentation. The time criterion is met, the emotional signature aligns with attachment pain, and the screening measure supports clinical judgment. This combination substantiates a diagnosis of prolonged grief disorder. This module reviews the primary evidence-based treatments for prolonged grief disorder. We will focus on structured therapeutic models supported by clinical trials and systematic reviews. The goal is to understand which interventions are effective and why, without going into applied dialogue or session scripting. PGD treatment involves both exposure elements and meaning reconstruction. Avoidance maintains the stuckness, so gradual engagement with memories, emotions, and reminders is essential. Treatment also supports the development of a revised identity and renewed engagement with life. Prolonged grief therapy is the most extensively studied treatment for PGD. It incorporates exposure to the reality of the loss and structured exercises that support re-engagement with life roles. Controlled trials demonstrate substantial symptom reduction relative to supportive counseling. CBT-based grief protocols target cognitive distortions related to guilt, responsibility, or meaning. They also reduce avoidance behaviors and promote engagement in valued activities. These components help shift the grief process from static to adaptive. Mindfulness-based treatment approaches aim to increase emotional tolerance and decrease avoidance. They support clients in allowing grief-related emotions without suppressing or being overwhelmed by them. Evidence supports their role in improving emotion regulation and identity coherence over time. Randomized controlled trials support both prolonged grief therapy and CBT-based grief protocols as first-line treatments. Mindfulness-based interventions provide additional benefit, particularly for clients with high emotional reactivity or limited regulation skills. Effective PGD treatment is structured and time-limited. It progresses from confronting avoided grief-related experiences to integrating the meaning of the loss and re-engaging in roles and activities that restore functioning. PGD treatment relies on emotional engagement. If trauma symptoms, substance use, or severe depression prevent this engagement, those conditions are treated first. Once stabilization is achieved, grief-focused work is more effective.